Good morning, Ray.
Morning, Andrea. How are you?
Oops, wait, because I can't hear you. Let me see. Okay, now?
Yep. Perfect. Can you hear me?
Perfect. Yes.
Morning, Ray. Morning, Andrea. How are you? That's the live stream. Let me turn that off.
Okay, are we in the session already?
We're in a practice session right now.
Okay. So let me close a few things. Okay, you can see this, right?
Perfectly. Yep.
Perfect. Okay. Okay. We'll be back in 20 minutes.
Okay. See you then. Get some coffee.
Yes, I will.
Hi, Ray. Good morning.
Good morning, Luis. How are you? Hello, Dr. Pena. How are you doing? You look good. Rested?
Espresso. Good morning, everyone, and welcome to our International Colorectal Web Meeting. So from the chat today, we have pediatric surgeons joining us from Uruguay, Egypt, Philippines, Brazil, Saudi Arabia, Kenya, Iraq, and Pakistan. If I missed your country, please type in the chat, and I'm going to acknowledge at the end. So the purpose of today's meeting, we have 4 cases, but we're going to really focus on total colonic ganglionosis. This is because of a recent case, and you are all familiar with WhatsApp chat and a lot of discussion about total colonic ganglionosis. And then I realized there is a lot of confusion. So I thought it was better to have this meeting, clarify everything so everybody is on the same page when we are discussing total colonic ganglionosis. So I'm just going to present a case so we have something to discuss and to start the points. So this is a male patient born at 37 weeks gestational age, had no stool in the first 24 hours of life, but then received a glycerin suppository, passed meconium, and was discharged. At home, he had no stool and started with bilious emesis. So this is the abdominal radiograph when the patient came to the hospital from home. So look carefully. And with this abdominal radiograph, what would you like to do? An upper GI to rule out malrotation, a contrast enema to rule out Hirschsprung, take the patient to the operating room, or I don't know. So everybody please vote and we'll see the answers. Let's see the answers. And the majority said contrast enema to rule out Hirschsprung. I think with this abdominal radiograph, we're all suspicious of a lower obstruction, but this patient was seen here in our hospital, and the protocol is if a newborn comes with bilious emesis, you have to do an upper GI first to rule out malrotation. So the patient underwent an upper GI, and you can see here the C curve that it's completely normal, cross the midline, so it was not malrotation. Then the patient received a contrast enema. And this is the contrast enema that was done. And I'm going to show all the images. And this is the final image. So with this contrast enema, what would you like to do next? A suction rectal biopsy, a full thickness rectal biopsy, start rectal irrigation, exploratory laparotomy, or I don't know. Everybody can vote. And we have answers all over the place. I think at this moment, we are all very suspicious that this is a case of Hirschsprung. So you can start rectal irrigation. If the patient was in front of me, I would do a rectal irrigation, and I prefer to do full thickness rectal biopsy, so there are no questions. But in newborns, the majority would do a suction rectal biopsy. So on day of life 6, he was taken to the operating room for leveling, colonic biopsies, and ileostomy. And the diagnosis was total colonic ganglionosis. So the next question is, when would you recommend to do an ilioanal pull-through, or whatever pull-through you do for total colonic ganglionosis? At 3 months, 6 months, 12 months, 18 months, 24 months, or none of the above? And we have answers all over the place, but the majority said none of the above.
Said what?
None of the above, not any of these ages. So the first important point of discussion is why we don't recommend an ilioanal pull-through in a baby. Do you want to comment?
Sure. You know, the babies have no bowel control. Even they have all the necessary mechanisms to have bowel control, but they don't, you know, they just let go the liquid stool or any kind of stool. If we do an ilioanal anastomosis, the baby is going to be passing liquid stool all the time. He will not try to hold it because you try to hold it after 3 years of age. That's when children become continent. But before that, they just let it go. So even if you do a perfect rectal pull through and preserve the sphincter and preserve the anal canal and preserve sensation, the baby will let it go and will pass and will have the worst diaper rash that you can imagine. So we are against the idea of doing that, even talking about perfect ilioanal pull through. Now, in addition, if during the operation, the surgeon manages to damage the anal canal and damage the sphincter, then it's going to be much worse. It's just like an ileostomy in the perineum, and it's the worst quality of life that you can imagine. The patients develop a terrible granulation tissue in the diaper rash, and it's non-manageable diaper rash.
Dr. De La Torre, do you want to comment about how to do a contrast enema?
Yes, of course. Can you hear me?
Yes.
Yeah, the most important recommendation is first not to use barium like a contrast. Try to use any other hydrosoluble contrast, but not barium. This is a very important recommendation. Second, try to do the contrast enema without bowel preparation. Number three, you need to use a small catheter and just insert like a 1 centimeter in the rectum, because if you introduce the catheter more than that, you can overpass the transition zone in cases with rectosigmoid ganglionosis. And then you need to hand inject the contrast slowly. There is no need to make too much pressure. You need to draw in, you need to feel slowly the distal portion of the large bowel, so you can see how is the shape, the size, and the form and everything of the distal colon, which is the most important. And then if you don't see any transition zone and you keep seeing narrow, like this image, the rectum and the sigmoid, you can continue feeling all the colon, and probably you can get this type of image. Thank you, Andrea.
Perfect. So I'm gonna advance my slides again because we're gonna. So our conditions for when to do an ilioanal or when to close the ileostomy are that the patient is toilet trained for urine and the patient accepts rectal irrigation, just for the reasons that Dr. Peña explained. If you do it in a baby, the baby has no bowel control, the baby will be stooling on diapers, and you will have terrible, unmanageable diaper rash. Now, if you do a technically correct ilioanal pull-through, preserve the anal canal. Yes, the patient will have several bowel movements, but the bowel movements will happen in the toilet. And you can do rectal irrigation to decrease also the chance of enterocolitis and the amount of bowel movements. And then it's manageable. And as the patient starts eating, hopefully, in the ideal scenario, you have 4 to 6 bowel movements a day. But it's very important to only do the ilioanal pull-through if the patient has demonstrated toilet training for urine and accepting rectal irrigations. So this patient was initially managed by another colleague, and then the patient, back to our case, came because of ileostomy prolapse. So Dr. Peña, do you want to comment why prolapse happens?
Yes. So the prolapse is a very common complication in the kind of surgery like we do. That is, we do stomachs, all kind of stomachs because of our specialty, and we receive patients with ileostomies and colostomies, and that means that we have been exposed to literally all kinds of colostomies and ileostomies, and from that I learned what you see in this diagram. The colon has mobile portions and fixed portions, you know. This is the descending colon is a fixed portion of the colon, fixed to the posterior wall, and the ascending colon under normal circumstances is fixed colon. The hepatic flexure is fixed, the splenic flexure is fixed. Now, the transverse colon is mobile, sometimes so mobile that reaches the pelvis. And the sigmoid is very mobile, so mobile that sometimes it reaches the upper abdomen. So if you open a colostomy in a fixed portion of the colon, it will never prolapse. If you open a colostomy in a mobile portion of the colon, will prolapse. If you open a colostomy, the sigmoid will prolapse. If you open an ileostomy, it will prolapse. That's why if you have to do a stoma in a mobile portion of the bowel, you're supposed to fix the bowel at least 5 or 8 centimeters to the anterior abdominal wall in order to avoid the prolapse. Otherwise, for sure, you will have prolapse. And the prolapse, in addition to being very bothersome for the child, sometimes is dangerous. And then even worse is that when those babies with severe prolapse, when the bowel starts getting dusky, they go to the emergency room, to a hospital where they don't have the subspecialty, and some surgeons simply amputate the prolapse, which is a terrible mistake.
So when we have a prolapse, first of all, when we do an ileostomy in a patient with total colonic ganglionosis, we fix the bowel proximal to where the stoma is to the abdominal wall to avoid prolapse. But if the patient comes with a prolapse, what we do is, once the patient is under anesthesia, we gently reduce the prolapse by introducing packing gauze with betadine, and then we're gonna palpate where we can feel that sausage of packing gauze that we place. So in this case, for example, we are palpating here, and then we're not gonna touch the stoma. We're just gonna make an incision here in the skin, subcutaneous tissue, aponeurosis. Then we're gonna confirm that this is the bowel. And as we're closing the aponeurosis, we're gonna get bites of this bowel and then close subcutaneous and close the skin. That's how we take care of the prolapse. So here you can see a diagram. We insert the packing gauze. Then we're gonna open, identify the aponeurosis, open, identify the bowel. And then as we close the aponeurosis, we take a bite in the bowel. So the bowel is now fixed.
So when you use the packing gauze and reduce the stomach, you don't know in which direction that bowel will go. In other words, sometimes you use the packing gauze, and then you palpate the abdomen. You may feel the sausage here or here or here. You never know in which direction. But wherever you palpate, that's where you open. In this particular case, the bowel went in this direction, and that's why you open and you will find immediately the distended bowel with a piece of gauze inside.
The other important thing is if a patient has an ileostomy, those are usually newborns or babies, we want to make sure that their urinary sodium is normal. So every time we see the patient in consultation, we get a urinary sodium. And if it's lower than 20, we start oral sodium supplementation. So here in the United States, we have to manipulate, but we start with 1 mg per kilo every 12 hours. Then we redose after a month. And if we need, we increase to 2 mg per kilo. And that allows the patient to grow properly. Now, if the anal canal is damaged, and Dr. Peña already mentioned that, during the ileoanal pull-through, there is no diaper cream, there is no bowel management, there's no laser therapy, the patient will need a permanent ileostomy. And that's the portion that most surgeons get confused. We received a lot of calls. What cream do you recommend, or what do you recommend? And we always ask, is the anal canal intact? Because if the anal canal is not intact in a patient with an ilioanal pull-through, the patient will need a permanent ileostomy.
See, some surgeons ask me sometimes, how come patients with anorectal malformations who they don't have anal canal, and yet they have some degree of bowel control? So, and the answer is, if I remove the anal canal in one of us, we still preserve the colon, and the colon is our reservoir. Our colon doesn't move constantly. The colon is wonderful because it decides to empty every 24 hours or every 48 hours. In the meantime, it's not moving. That's what the colon is. It's a reservoir. Patients with total colonic ganglionosis, by definition, when we operate on them, they have no reservoir. We are connecting a small bowel that has a constant peristalsis connected to the skin. So with no anal canal, basically that's an ileostomy. And as Dr. Bishop said, there is no treatment for that diaper rash. Don't waste your time.
So this is the worst diaper rash that we have received. This was a patient that had an ilioanal pull-through with damaged anal canal, and the patient could not sit because he was in severe pain. And again, the mother came thinking that we could offer bowel management or that we had good creams. And then Dr. Pena had to have the discussion saying that the only treatment for this boy was a permanent ileostomy. It's not an easy discussion. Now, back to our case. When the patient has an ileostomy and the patient received the ileostomy in the first days of life, we're gonna wait until the age of toilet training. But during that waiting, we want our parents to train to do rectal irrigations, so the child is something natural for them. So the parents of this patient were really struggling to do rectal irrigation. The patient had one admission due to enterocolitis, but unfortunately he was diagnosed with nonverbal autism, and the family said they did not foresee a chance for an ilioanal pull-through or a chance for toilet training anytime soon. Therefore, they would like to proceed with a colectomy without the ilioanal pull-through. So one of my colleagues did the laparoscopic colectomy until the peritoneal reflection. Then we turned the patient prone and we did the transanal dissection. So here we just placed the Lone Star hooks into the skin so you can see an intact anal canal. And now we're gonna advance and protect the anal canal. So now the anal canal is protected underneath the hooks. And we're gonna start our dissection 1 or 2 centimeters beyond proximal to the anal canal to be sure that we are protecting the anal canal. So we place multiple 5/0 silk stitches for traction, and then we dissect it. And at this point, we reached the peritoneal reflection and we were able to meet the laparoscopic dissection. So you can see that the bowel was coming, but I didn't want to pull the entire colon without seeing what was going on in the abdomen. So we turned the patient supine again. They placed the camera, and then I was able to pull the entire specimen with the patient in supine position, making sure that no small bowel was coming as we were pulling. So here's the entire specimen. And here again, because this patient, there is no anticipation of an ilioanal pull-through, I decided to close the anus. So this is just to show you how the anus looks after my dissection. It looks exactly like the picture that I showed you at the beginning of the operation to prove you that the anal canal was preserved. And now I'm gonna advance the hooks and you're gonna see where my dissection was. So this is just to demonstrate that the anal canal was fully preserved in the event that this patient develops better than what we expect, and he asks for an ileal pull-through. So in this case, I just closed this area, but his anal canal is completely preserved in the event that he desires an ilioanal pull-through in the future. So here's the closure, and you can see that the anal canal is perfectly preserved. So now, yeah.
I'm sure all of you are familiar with the cases of adult patients who need a total colectomy for different reasons: inflammatory bowel disease, ulcerative colitis, and those adult patients need an ilioproctoanastomosis. So the colorectal surgeons must be extremely careful to preserve the anal canal and do the anastomosis at least 2 centimeters above the pectinate line to be sure that they preserve the anal canal. By preserving the anal canal, we are also preserving the anal sphincter. So those patients under perfect circumstances with an excellent surgeon that performs the operation, next day after the operation, they have to learn to control liquid stool because the small bowel will keep moving constantly. Our small bowel is moving constantly. It's not a reservoir. The small bowel is trying to empty constantly. So the person who experienced that goes through that operation must be perfectly aware of the fact that constantly the bowel tries to empty. But if he has an intact anal canal, he will feel it. But even with a perfect operation, it is well known that many of those patients suffer accidents, particularly at night, because it is like having a terrible diarrhea. So they have to react immediately and contract the sphincter. So the accidents happen even under perfect circumstances. So now, if you do that same operation and in a little baby, the baby doesn't hold that. And that's why they have diaper rash. And if you damage the anal canal, absolutely contraindicated an ileal pull-through.
So this is another case. This case I have presented before. It's just because it's a patient with a long-term follow-up. So this is a developmentally normal patient. She met the criteria. She accepted rectal irrigations. The parents could demonstrate in clinic for me. She was toilet trained for urine, and they wanted the ilioanal pull-through. So we did, again, preserving the anal canal. We did the colectomy and the ilioanal pull-through, and you can see that the anal canal is preserved. Again, this is the anastomosis, and this patient has 4 to 6 voluntary bowel movements per day. So our post-operative protocol. So patients with total colonic ganglionosis, they have very high chance of having enterocolitis post-operatively. So we are very conservative. We keep the patients, if the patient has no stoma, we keep the patients NPO for 7 days on TPN. If the patient is passing stool and it's not distended, great, we just wait for the 7 days. Sometimes around day 4, day 5, the patient starts getting distended. If that happens, we will start rectal irrigations. And the first ones obviously have to be done by the surgeon because of the fresh anastomosis. And then we send the patient home with 3 rectal irrigations per day and flagell 3 times a day for a month. Then in the second month, we decrease to 2 times a day and flagell 2 times a day. And in the third month, rectal irrigation once a day and flagell once a day. And by that time, we hope that the patient is already in a good bathroom schedule for patients with total colonic aganglionosis. 1 month after surgery in clinic, we're going to do a digital examination. And if we feel our suture line, we will start anal dilations. Any questions about our post-operative protocol? Okay, I see that there is a lot of questions. Dr. De La Torre, can you do this procedure laparoscopically, small bowel PECC? I think that's for the ileostomy prolapse.
Yeah, I think it's a prolapse. Yeah, if you have the experience and the abilities to do it laparoscopically, you can do that.
So there is another question. Isn't it possible that an anal ileostomy is easier to manage than an abdominal ileostomy? Doesn't the ileostomy get colonic-like function over time in teenager adults? So that's the confusion. So if you have an ileostomy with a bag, you have protected skin. If you have an ileostomy in the perineum, you don't have a way to protect the skin. You will have the worst diaper rash, unmanageable, extremely painful in a patient without bowel control or in a patient with damaged anal canal. So in a young patient without bowel control or in a patient with damaged anal canal, no, it's not better to have an ileostomy in the perineum based on the picture that I just saw of what the diaper rash can look like.
And let me, the second part of your question was, you asked if the terminal ileum develops colonic characteristics that make it work like a colon. The answer is, don't confuse dilatation of the small bowel with colonic characteristics. Okay, yes, the small bowel become dilated because in a case of a perfect operation, the patient will try to hold the stool all the time, walking in the street, but always contracting the sphincter. So the small bowel start getting dilated. So yes, the small bowel, as time goes by, start being dilated. But remember, the small bowel is not made to absorb water. The water absorption happens in the colon. That's why the small bowel always has liquid stool. So the small bowel becomes dilated, but that doesn't make him colonic. He doesn't absorb water and doesn't have the motility characteristics of the colon. The motility characteristics, the colon is relaxed all the time and only contracts once in a while. In the case of the sigmoid, it contracts the size depending on your habits every 24 hours. In the meantime, it's quiet. The small bowel is constantly moving, and that doesn't change with time. So yes, it becomes dilated, but doesn't work like colon.
So the question, why didn't you staple across the rectum as low as possible? I think that was for the case that I presented. This is certainly a possibility because I have done many reoperations and I thought if this patient needs an ilioanal pull-through, I'll be the one doing it. I didn't want to have staplers and I didn't want the pelvic to be dissected because I have been in nightmares in reoperations, but that was certainly a possibility. In cases of total colonic ganglionosis, is there any advantage of Duhamel procedure over the Swenson procedure? Do you want to comment? Luis, do you want to comment?
I think the original description for Dr. Lester Martin, I hope I'm not wrong, but he always did the colonic pouch and the colonic patch, and he was using Duhamel instead of Suave or Swenson. So in worldwide, many surgeons believe that the technique, this is a very common question, the technique to do a pull-through in a total colonic should be done with the Duhamel. This is always a very common question in the chats, in the groups. Everybody said, if the patient needs a pull-through because the patient has total colonic, so he needs a Duhamel. Short segments or large segment or long segment, they need Suave or Swenson. It's something that is very confusing. I think the Duhamel in these times does not have a good, it's not indicated in patients with total colonic. I think Suave or Swenson, even better in Swenson, is the best technique for total colonic. But if the surgeon, they do a very good Duhamel, I think the patient is going to be fine.
The other question for total colectomy with ilioanal anastomosis, the ileum is left overhanging ex vivo with substantial length during the first operation with good blood supply, called as hanging bow technique, followed by a few days, the surgeon goes back and resects under light anesthesia. I don't know what is LA.
Could be laparoscopic assisted, I don't know.
Okay.
Could be.
Let me see if I understood the question well.
Yeah, I don't understand.
Are you referring to the idea of Dr. Suave of leaving the colon outside the anus in the bed of the patient for a week to be sure that he has good blood supply, and then go for a second procedure to resect that piece of bowel? I remember assisting a surgeon doing something like that, and it's the most disgusting procedure that I have seen. We don't do that. And we don't do that because if you do a good operation, if you manage the blood supply adequately in the bowel, you don't have to do that. You can see that your bowel has very good blood supply. If you are in doubt, you're supposed to go a little higher. You are supposed to do the anastomosis in a bowel with demonstrated good blood supply. So that procedure is for me is kind of disgusting. I don't like that, to see the patient with a piece of bowel hanging out in bed. That was very, very ugly. I put it that way.
I don't think anyone does that anymore. At least I have never heard of it. Now, the question about the proper age for pull-through, I'm assuming you're asking in a patient with total colonic ganglionosis. So again, the criteria for that, the patient has to be toilet trained for urine and accepts rectal irrigation. I don't think it ever happens before 3 years of age. And there's no harm in keeping longer, doing it at 6 years of age. There's no harm.
And let me emphasize the importance of that routine. A lot of people don't like that because it is fashionable now to say, I do these procedures 1 year of age. Then another surgeon says, no, I do it 6 months. Then another says 2 months, 1 month, newborn, prenatal. You know, it's a kind of a competition. But sometimes that competition doesn't benefit the patient. We have to do the procedure when it's better for the patient. Why did we select 3 years of age? Because most children in the world have bowel control and urinary control by the age of 3. And that's why you leave the patient with an ileostomy 3 years, and the patient doesn't bother him because he was born with that. He's happy. If you do a good ileostomy, if the mother takes good care of the stomach, the baby is happy. Why do we say as a requirement that the patient must accept rectal irrigations? Because if from the time that the patient is a baby, you start irrigations, you just simulate an irrigation, you just pass the catheter in the anus for him to know that doesn't hurt at all. So, but assuming that patients with total coronary ganglionosis frequently need irrigation because they have enterocolitis or because you want to decrease the amount of liquid stool to make the diaper rash more manageable. So there are high chances that all those patients with total coronary ganglionosis need rectal irrigation. If you try to do rectal irrigation in a patient with a diaper rash like the one that we show you, he will not let you close to him. He will kick at you. So that's why it's completely different to a patient that the mother twice a week passes a little catheter lubricated in the anus just to let him know that doesn't hurt. So when you start the irrigations after the operation, the baby accepts that. We wait until the patient is toilet trained for urine, because when he's toilet trained for urine, he is now accustomed to having normal underwear, no diapers. He knows the difference between being dry and being wet, and he's accustomed to be dry. And that's why when we close the ileostomy in a patient that has normal sensation, normal anal canal, amazing. Within 5 days, the baby learned to hold his stool. if he's normal mentally. If the patient is delayed, that's a different story. May have a little difficulty in becoming toilet trained, but he's accustomed to be dry and it's relatively easy to toilet train him.
The next question, can we use the Lester-Martin procedure? Do you want to answer that?
Yeah. Right, I have the opportunity to meet Dr. Lester Martin, and we did a couple of those procedures in the old times. And the idea of Dr. Lester Martin was a great idea, but sometimes ideas are great, but in real life, it doesn't work in the way we expected. His idea was to anastomose the terminal ileum, normoganglionic, lateral to the descending colon, all the way down to the rectum. So by doing that, he had a bowel that now half of that is ileum with normal motility, and half of that is colon aganglionic. And he said, we would use the water absorption capacity of the colon, and we will use the normal motility of the small bowel. That's a brilliant idea. So now we have the right combination. Well, it doesn't work that way. We have to resect many of those cases because it was not working well. It becomes dilated and the patient have enterocolitis, and is that, I don't see an advantage in doing that procedure. We did it and we decided to stop trying that.
So there was another question of a patient with total colonic ganglionosis that it's continent during the day, but has stool leakage at night. What to do? So I never had a patient with total colonic ganglionosis with that problem, but I had a patient with ulcerative colitis with exactly that problem. And what I recommended was either trying to sit in the toilet before bedtime or doing which would be more effective, doing a rectal irrigation before bedtime, and giving, if the patient is not taking Imodium before bedtime. And for that patient with ulcerative colitis, that solved the problem. Let me see other questions.
Diet and fiber.
Do you want to comment on any question, Luis, that you have already
Yes.
answered? Okay.
Yes, there is a question. It says, what is better to do a ilioanal anastomosis or iliorectal anastomosis? That's the question. So just to be clear, all the patients with Hirschsprung, it doesn't matter if they have short segment, long segment, or total colonic. The anastomosis should be done above the anal canal. Our anatomical, I want to say the anatomical structure that guide us during the pull-through to perform the anastomosis is the dentate line or pectinate line, as you know it. And then we leave some millimeters above to stay safe and prevent damage of the anal canal. So if you understand this concept, then we never do ilioanal or coloanal anastomosis. We always do the connection, we do the anastomosis, end-to-end anastomosis using colon or using ileum to the rectum. So millimeters of rectum, we have to leave some millimeters of rectum. Somebody wants to leave 5, 6, 9, 10, whatever, millimeters of rectum. I understand that this rectum is aganglionic, but if you try to do the anastomosis in the anus, in the anal structure, in the anal canal, then the patient is going to be fecal incontinent. So I like the question because now is the time to clarify. You never have to do an ilioanal. That's wrong. Should be iliorectal or colorectal. But never try to do something in the anus.
You're right, Luis. And I have to say, I always say ilioanal, but I always do an iliorectal. So I'll try to correct my English because those are semantics, but are important. I agree. We may be inducing people to do it wrong.
But there is perhaps the person that is asking that question is thinking, what if we leave more rectum? In other words, we do exactly what Dr. De La Torre does, but what if we leave more rectum, a piece of rectum, and to leave some reservoir? Well,
That's really
that's what Rebine was doing, Germany, and says that, and many surgeons believe that that works. And I don't have experience doing something like that, but I guess that if you leave 3 or 4 centimeters or more rectum, it's not going to have a lot of significance. Now, if you leave the rectosigmoidal ganglionic, then you will have enterocolitis and all the problems that we already know.
So there is a question about Botox post pull-through. I don't have a protocol of doing Botox. I prefer to do irrigations and then stop the irrigations and start them on laxatives if needed for patients with short segment Hirschsprung. But I don't do Botox. Luis, do you want to comment?
Yes, in patients with total colonic, I use Botox. But in patients with total colonics, I have not used yet. I don't know if in the future I'm going to use in some cases. But I never have used. I use in patients with the rectosigmoid Hirschsprung, and it's not the treatment for the enterocolitis. Botox is just, I want to say, an auxiliary method, a coadjuvant treatment when the patients need irrigation, and more irrigation, and then you did a very good exam on the anesthesia. There is no structure, there is no stenosis. The biopsy of the neorectum, in other words, the bowel that you place in the pelvis, and now it's going to be the neorectum. This portion of bowel should be biopsied. You need to obtain a biopsy of this portion just to be sure that you are not in an aganglionic pull-through. If this biopsy came normal or with ganglion cells in both plexus, there is no anatomical structure or mechanical structures, and the patient is needing irrigation, yes, I use Botox. And that facilitates the parents to wean slowly the frequency of these irrigations. Somebody was asking about how we do the irrigations. If you go to the answered questions in the middle of the tab, I placed 2 links that you can see. One animation from the Colorectal Center in Children's Colorado, and this animation is going to show you how to do irrigations. And there is another link with a video doing irrigation in a patient. Enema versus irrigation. Andrea or Alberto?
Yes, this is just because we realize there is a lot of confusion between what's an enema and what's an irrigation. So we have to remember, patients with Hirschsprung, they have incapacity to empty before they have the pull-through. So those patients, we're gonna place a large Foley catheter, so between 18 or 22 French, and we wanna drain all the liquid stool. So irrigation means passing a Foley, letting the liquid stool drain, and then we inject 10 to 20 mLs of saline and let it drain, 10 to 20 and let it drain. So you need more out than what you put in, but you're actually doing this mechanically, cleaning. Whatever you put in, you have to get out. And you're gonna get packages of gas too. You're gonna hear the gas coming in patients with short segment Hirschsprung. Now, enemas is the treatment that we do for patients with fecal incontinence or for patients that are fecally impacted. That's a different treatment. Then we're gonna inject a large amount, a large volume, and the patient will empty on their own. It's completely different. But patients with Hirschsprung, parents should know how to do rectal irrigations because this is a life-saving maneuver. So for our patients, even after the pull-through, I always tell the families, have the supplies to do rectal irrigation always in your luggage. If you're traveling, your supplies have to go with you, because a patient with Hirschsprung is always at risk for having enterocolitis even after the operation. And sometimes the family gets a GI bug or a virus, a respiratory virus in the patient with Hirschsprung that may be an episode of enterocolitis. So you should never do a pull-through for Hirschsprung if the family does not know how to do rectal irrigations. Our patients are masters on how to do rectal irrigations. It's very important. Can I comment?
Yes. Enemas are contraindicated in a patient with Hirschsprung. In a patient with Hirschsprung that has not been operated, the rationale of the enema, it goes like this. You introduce a volume of liquid with different types of irritants that make the colon contract and empty. In Hirschsprung, the colon doesn't contract. That's why you put enemas, you may make the patient worse. So that's an enema. And so irrigations are done to deal when you deal with liquid stool, and you only facilitate the coming out, the expel of the liquid stool through a large tube. You pass a large tube through the rectum, and through the lumen of the tube, the liquid stool will come out in an explosive way, liquid stool and gas. And that, as Dr. Bishop said, may be a life-saving maneuver in a patient with enterocolitis. We make the mothers of our patient with Hirschsprung paranoid against enterocolitis. When we discharge the mother with a baby with Hirschsprung that we operated, the mother already knows how to do irrigations. We never let them go home without the mother demonstrating the technique of irrigation. And then we tell the mother, it's a Friday night, your baby starts having fussy crying, it looks distended, and is vomiting and has fever. And you decide to take him to the hospital. Before you go to the hospital, do the irrigation in the way you know. Because otherwise, if you go to the hospital, particularly if you go to a general hospital or a hospital that has no experience with Hirschsprung, they will not know what to do. And so do the irrigation and then take the baby to the hospital. And even in the hospital, you should demand that the baby should be seen by somebody with experience in Hirschsprung. A general pediatrician, an emergency room doctor will see your baby and will say, put an IV. They confuse enterocolitis with gastroenteritis, completely different, very, very important. The gastroenteritis, the viral gastroenteritis of a child, they just put an IV and wait, but to avoid dehydration. Enterocolitis is a very serious condition that includes endotoxemia and kills the babies, and should be suspected, and usually suspected by people that is familiar with this, somebody expert in colorectal pediatric surgery.
So I know, Dr. De La Torre, I know you're typing the answer. Do you want to comment so everybody can hear? A patient of Hirschsprung disease underwent ganglionic segment pull-through, and after 2 years is still not passing stool spontaneously despite no stenosis. I'm afraid she got acquired ganglionosis.
I think, Dr. Asim, if you have this patient, I will recommend first to do an EUA. I think you did it because you said the patient does not have stenosis. If not, you need to use a very good exposure of the anal canal, and you need to look the colorectal anastomosis. I need to be sure there is no mechanical obstruction. Sometimes you can introduce a Hagar number 14, even 15. But when you do the digital exam, the anastomosis is completely fibrotic, so it's not elastic. Then you need to do a contrast enema and see if the proximal colon to the anastomosis is dilated or not. If the patient has chronic obstruction, severe obstruction, then the colon is going to be dilated. And finally, you must take a full thickness biopsy of the neorectum, not the rectum, should be above, proximal to the anastomosis. And then you need to go back and look the specimen that you resect, and then look for the all the circumference that we call the proximal margin. So all the circumference of the proximal margin should possess complete ganglionated submucosal and myenteric plexus and no hypertrophic nerves. The possibility to have an acquired ganglionosis is a possibility. It's something that is described, is something that I have seen in very, very few patients. We performed the pull-through, the proximal margin came completely full of ganglion cells everywhere, and then we go back to the OR, and then we take a biopsy, and the big surprise is aganglionic. There are many reasons to explain this. One is a failure taking the biopsy, and we leave too much rectum, I want to say more than 1 centimeter, and we take the biopsy from the rectum instead from the neorectum. If the biopsy is actual from the neorectum and is aganglionic, the hypothesis described in the literature, I don't have any study about it, but I have read a lot of this. They said is if you do a ischemic pull-through, no well-irrigated bowel, then the ganglion cells can die, and then you can have aganglionic areas. Is my comment.
There is one more question. A patient had a pull-through surgery. The proximal part of the specimen came 25% of circumference hypoganglionic. Patient had an ileostomy. Should we redo the pull-through? I personally don't know what hypoganglionic means, so I would have to see the specimen, discuss with the pathologist. And just going back to the previous question that Luis was mentioned about acquired aganglionosis, I know there is not proven theory, but I suspect that the acquired aganglionosis is in a very short segment. It's not the entire bowel.
I don't see the question.
Therefore, I would try to treat the patient with laxatives, because I think most likely the patient will respond to stimulant laxatives. I am very conservative in trying everything prior to offering a redo pull-through. Redo pull-throughs are not always straightforward, not always easy. And remember, you can always make things worse than what they are. So I am very conservative, and I try my best not to reoperate on a patient unless there is a clear evidence that I need to reoperate on a patient.
Okay. Can I comment on this question? I didn't see it.
Yes, it's the one before the last one in the chat. So it's
in the chat.
Yes,
Okay.
25% of the circumference is labeled as hypoganglionic.
Okay, I think this, I don't see it, but it doesn't matter. I think this doctor is asking this question because based on the very, very scientific publication of Raj Kapoor, currently there are 7 histological abnormalities in the transition zone. But at the end, he said only 3 could be identified in the proximal margin. One of them is this. So if you have the circumference, and then the pathologists divide the circumference in 8 portions, so half, quarters, and an 1/8, if one of these 8 portions has 1 ganglion cells in the myenteric plexus and 1 ganglion cell in the submucosal plexus, this is what they call hypoganglionosis in this portion. Somebody can say 25%, so you need to divide the donut in 4. So 25 of the circumference is hypoganglionic. Honestly, when I talk with the pathologists here in Colorado and when I was in Pittsburgh, I have the fortune to work with very, very good pathologists in Hitchburg. And they said they never have seen this abnormality. It's very challenging for the surgeon, for the pathologist, to divide all the circumference and then to divide in 4 portions and then 25, 25, 25, 25, trying to find if the patient has hypoganglionosis defined in the papers of Kapoor based on the numbers of ganglion cells, 1 to 3, and hypertrophic nerves. It does the definition of hypoganglionosis from Raj Kapoor. Even though, if you do a pull-through in a transition zone, we have a study that has been very difficult to publish, that we compare patients with normal proximal margin versus patients with a transition zone in the proximal margin. Both groups have the same outcome. They have the same frequency of bowel control, bowel movements, the same amount of enterocolitis, and the same frequency of constipation. So there is no difference. Instead, when we have a patient with transition zone and somebody want to do a redo, all these patients are fecal incontinent, 100%, because they want to do the redo because they are afraid they did a pull-through in a transition zone. Is something that you need to know. Thank you, Andrea.
Okay.
When we started learning about Hirschsprung disease, all the emphasis was on ganglion cells, yes, or ganglion cells, no. We have learned through the years that the story is much more complex than that. We have patients with a perfect pull-through, with perfect normal ganglion cells that behave like having obstructive symptoms. No mechanical stricture. They have a pull-through perfect normal ganglion cells in the pull-through. The technique was perfect. The patients don't behave well. They have enterocolitis, and that is a secret. Nobody knows why the bowel behaves that way. So the so-called normal bowel, normal ganglionic, is not really normal, or has different degrees of behaves in an abnormal way. So sometimes you do the same technique in two same patients. One is perfectly bowel controlled, no enterocolitis like a normal life, and the other one has a lot of problems, retention of stool, enterocolitis with completely normal ganglion cells. That means that to me looks very naive to believe that leaving a little piece like that or in the one area, not in the other, is going to determine the symptoms of the patient based on the experience that I'm just telling you about. I don't believe that's true. We have been paying extremely. I don't mean to do pull-throughs aganglionic bowel. No, don't mean that. We should follow the rules of the pathology, but I don't pay so much attention to that. And I always go from the area where they say transition, I go like 10 centimeters above to be sure that it's a normal bowel. But even under those circumstances, many times that bowel doesn't behave like normal, and we don't know why. It's a new generation, a new basic scientist that will come up with explanation. That bowel that we pull down is not 100% normal.
So there is one more question that we missed, was about the incidence of enterocolitis after pull-through. So generally speaking, it's about 30%. When you have a correctly done pull-through, you still have 30% chance of enterocolitis. It's very interesting that it seems like enterocolitis is more common in certain countries than others. I don't have a full explanation for that, but I think in the future we will have.
Can I say something?
Yeah.
Let me tell you, this is my own idea, okay? But watching so many patients with Hirschsprung disease through my life. In Mexico and in other countries, we still see patients that come 12, 14 years old with Hirschsprung disease, with the giant abdomen, the colon giant, and they never had an episode of enterocolitis. And in the United States, we are seeing more and more newborns whose first manifestation is abdominal distension and enterocolitis. At birth, they get very sick. So I believe that there are two kinds of Hirschsprung disease, a kind of that I call benign, that these patients don't die and they live 12 years without an operation because they don't have enterocolitis and they never had. And then though you operate on them and they are perfect. And and the babies that have enterocolitis from the first day of life, and that's some sort of bad Hirschsprung, I call it. So I cannot tell you more about that. I'm not a basic scientist, but I'm sure somebody will study those two groups of patients going to underdeveloped countries to detect those patients with a big abdomen. Even in New York City, I remember operating on the son of a surgeon who was 14 years old, a giant colon, never enterocolitis, but the abdomen like that. And I repaired that, and he was like a normal person, never had a problem. So there's I believe, two kinds of Hirschsprung disease.
There is a question about, is it dietary? The reality is we don't know. I suspect one day we'll find out, for the same reason why we see so many inflammatory bowel disease in developed countries and we don't see in underdeveloped countries. So I think it's probably the same mechanism, but I don't know. It's just a theory. Well, I think today was very productive. I had 4 cases to present, but I only did 1 because I realized there were a lot of questions and a lot of confusion about total colonic ganglionosis, and we achieved our goal. I think we discussed at length, and I hope you have all enjoyed, learned, and that you can all see the video of how to do rectal irrigation. If you take home this message of rectal irrigations and to preserve the anal canal, we have accomplished our mission. So thank you very much for joining. So we had pediatric surgeons from Uruguay, Egypt, Philippines, Brazil, Saudi Arabia, Kenya, Iraq, Pakistan, Siberia, Indonesia, Spain, Kazakhstan, Romania, Armenia, United States, Mexico, Uganda. I obviously missed a few. Uganda, Czech Republic. Thank you so much for joining, and we'll see you next month. Bye-bye.
Bye-bye.